Request Dr. Yogesh Pal sir to introduce our first honorable speaker and to take the CME forward. I would also like Dr. Sandeep Contour to interject in the second CME, which will be on critical care. We would like his insight as to what they are doing in Muscat. So, friends, kindly be attentive, and if there is less noise of cutlery, we will be able to record it beautifully and put it on YouTube for all of you. Then world becomes your audience. Thank you.
Thank you, Dr. Chauhan, for giving me the privilege to introduce Dr. Sanjay Chaudhary. It's a wonderful experience being here every week. Sanjay Chaudhary, hello. He has an experience of over 21 years in neurology. He's a graduate from Calcutta Medical College, and he did his MD in medicine from MGM Medical College, Indore, and then a DM in neurology from the prestigious All India Institute of Medical Sciences. Presently, he is a senior consultant neurologist at the IBS hospitals. Previously, he has been a senior neurologist at Batra Hospital and Mulchand Hospital. His areas of expertise are stroke, dementia, movement disorders, epilepsy, headache, vertigo, neuroelectrophysiology, ADHD, sleep disorders, Alzheimer's, Parkinson's. Today he will be speaking on recent advances in dementia. The treatment so far for dementia was mostly around providing comfort and support to the patient and to the caregivers. Or we used to give symptomatic relief with acetylcholinesterase inhibitors or NMDA receptor antagonists. But now we have a few more methodologies of treating, like the TMS and monoclonal antibodies. So I welcome Dr. Sanjay Chaudhary to tell us more about what is new in the line. Please, sir. Please give him a round of applause.
Thank you, Dr. Paul. Thank you, all the seniors, Dr. Tulsi, Dr. Vikas, and all colleagues and dear friends. And it is a pleasure for me to come the second time around to have a small talk with you, basically to share my experiences and what's new in the field with all of you, so that we have understanding of some of the common disorders. Last time it was stroke, this time it is dementia. So to begin with, I will start the talk without much delay. So I am going to speak to you for half an hour or so. I will try to cut down as much as possible, as Dr. Tulsi has requested. The concept of the talk is that I will go through these important topics, like the...
Dr. Sanjay, probably we will have more interactions, that's why
yes,
I
so I will go through the
please.
basics, and then we can have interactions. Please. Yes. So I will discuss about what is memory, cognition, how is it changing with aging process, what is MCI, mind cognitive impairment, and dementia continuum. It is nowadays not separated much, and the burden of the dementia which we are going to see in the coming decades, the biomarkers for cognition impairment, because exciting developments have happened in the field of biochemistry and neuroradiology and functional imaging, and then coming to a diagnosis of dementia. The clinical diagnosis is still the main aspect. We have to take the help of lab work and treat the treatable ones, so that we are left with the non-treatable ones and we manage them as we go. Then we'll management of dementia next will be the topic, and lastly I will add the recent advances, both the medical as well as the therapeutic advances which are there. Finally I will conclude with, so to begin with, what is memory? Memory is the ability to store and retrieve information. It can be in stages, like immediate, and if I rattle you a mobile number, if you remember it, that is immediate memory. We call it digit span. Then there is a short-term memory, which is a working memory, and it lasts from seconds to minutes. But every immediate memory is transferred to short-term memory and thereafter to remote memory. Remote memory can be either procedural or it can be declarative, for example, knowledge. For example, what is the color of milk, name the 4 birds. So these knowledge we have. But what is episodic memory? That is most important. It is personalization of the memory. What happened? Where did it happen? Where did it happen? For example, last patient, when did the patient come to us? So these are more important ones. If not, then the whole memory process gets derailed. So amnesia is the loss of recent and short-term memory, as we have seen the movie Ghazni. The protagonist, he had loss of short-term memory, so he used to live in eternal present. He didn't have any past memory, so he used to have visual cues in the form of photograph for helping him in the course of the movement. It's more of a movie industry, but in real life we do see such patients. Then now we come to what is the activities of daily living. Whenever there is a memory, there is a change in the activities of daily living. There are basic activities of daily living as every child can do, like dressing, eating, bathing and toileting. But more than that, it is the instrumental activities of daily living. For example, driving, medication, financial management, shopping, using devices and preparing meals. These are the ones which are instrumental areas. If they get affected, then we have to think in terms of dementia happening. Cognition includes all conscious and subconscious mental process in which we are aware of what's happening around us by our senses, by our thought, by our experiences, and we include them and put it into our mind so that we are aware of what is happening. And when that declines, then we say dementia has started. So it is in different domains. For example, there is attention working memory, there is a memory, there is a language, there is a praxis, executive, intelligence, visual, perceptual, spatial, and psychological and social changes which happens. But the essence of cognition is judgment. What is right, what is wrong, what should be done, what should not be done. So if that gets impaired, then you are on for dementia. So the cognition decline occurs with aging. It is a natural process. The cognitive aging leading to cortical, subcortical and corpus callosum atrophy is a known phenomenon. But we don't call it dementia because patients are not having any deterioration in their quality of life, or the symptoms are mainly reported by the patients. So whenever a patient reports that I am having memory loss, we should not be much worried unless and until it is progressive or it affects the daily living or the quality of life. If change is noted, then we have to go for neuroimaging and neuropsychological testing. So what memory changes, we'll think that it is abnormal. So when you start forgetting things which are much more than before, when forgetting how to do things which you have done earlier, for example, you used to drive, now you're not able to drive. For example, trouble learning new things which you used to learn easily. Repeating phrases or stories in the same conversation. एक ही कहानी बार बार repeat करते हैं, तो that's suggestive of dementia. Repeating trouble making choices or handling money. सामान लेके आ गए, पैसे छोड़ के आ गए. Or not being able to take care of what happens every day. And time memory worsens. So if these things happen, then this memory impairment is serious enough for us to think in terms of dementia. Now, mild cognitive impairment and dementia, it is a continuum. As you can see in this diagram, initially there is no cognitive impairment. But as with age, yes,
yeah, that's fine.
So as age increases, there is a decline in the cognition. We call it mild cognitive impairment. Thereafter, then there is mild dementia. Finally, it is severe dementia. He said that almost in 5 years, about 40 to 80% of those who have mild cognitive impairment, they will get demented. And in fact, annual conversion rate comes to 10 to 15%. But we still don't label mild cognitive impairment as dementia. But it is on the threshold, like someone is knocking on the door. So we have to take care of them. So mild cognitive impairment, it is established clinical consensus. Patient is not normal, but not demented. So there is evidence of cognitive deterioration of age. There is objective measured decline by neuropsychological assessment. It is complained by the patient, by the relatives, and there are objective cognitive deficits. But they have preserved quality of life and they have minimal impairment on complex instrumental functions. So what are the more important things about MCI is, it is a very common entity. Risk of converting AD is substantial and can usually be predicted, as I said, 10 to 15 every year. And there is no good pharmacological treatment currently available or approved, but it is in the pipeline. The reduction of blood pressure, these are preventive measures. We think they are going to help us and encourage exercise and social engagement, etc. Now we come to the main topic, dementia. So dementia is a progressive brain dysfunction which results in a restriction of activities of daily living, leading to long-term need for care, be it at home, as in India, or in Western countries, they have to be institutionalized. Dementia initially started off with the word irascibility from Latin. Essential feature is that it is impairment in short-term and long-term memory, associated with impairment in abstract thinking, impaired judgment, and other disturbances of higher cortical function, and personality changes. The disturbance is severe enough to interfere with the work or social life or relationship with others. These are the different parameters which get involved with dementia. So dementia is a big umbrella. It has about 100 different causes of dementia. Main important is the Alzheimer's disease, 60 to 70%. Next is the Lewy body dementia, about 15 to 20%. Vascular dementia, 15 to 20%. Rest, the Parkinson's disease and frontotemporal dementia, 5%. These are the major causes of idiopathic, you can say, dementia. So I will first highlight the Alzheimer's disease. As I have said umpteen number of times, 70% of dementia are because of Alzheimer's. There is memory loss, personality change, and global cognitive dysfunction and functional impairment. Visuospatial disturbances are early finding. Later on, language function, apraxia, personality changes happen. There can be delusions, hallucinations. Sometimes they can be focal neurological signs also. So it is a grading. Initially it is early dementia. So mainly memory loss, aphasia, changes in functioning level, personality changes, emotional changes. Acute decline can happen in mild dementia with any infection, any hyponatremia. It can worsen the picture. Then we come to middle stage. Patient now cannot learn new information. The environment and social cues, they are not able to be understood. They have increased disorientation to time, place and person. They have risks of fall and accidents due to confusion and poor judgment. It's not that they are not able to have motor weakness. They don't have motor weakness. They're not able to do where to put the foot. That's how they fall. There is a behavioral disorders. There is significant paranoia. They are fearful. The neighboring people are trying to trap them or take up the money or kill them. They have wandering, as Sir said, Dr. Chauhan said. People sometimes walk out of the house and never to come back after years or so. They can be physical aggression, inappropriate sexual behavior, and non-specific agitation. And the activity to ADL is further impaired. Next comes the late stage dementia, the severe dementia, in which the patients cannot perform the activities of daily living. Their short-term and long-term memory are completely lost. They have difficulty with swallowing, leading to malnutrition and aspiration. Malnutrition and poor mobility leads to further bed sores. Incidence of seizures increases, finally leading to death. Death is from infection from respiratory, skin and urinary tract infections. So we have understood that dementia starts off as a normal aging process, goes into mild cognitive impairment, mild, moderate, severe dementia. So it is a whole gamut of information. So epidemiology wise is a big burden. As of now, internationally about 47 million, that is almost 50 crore cases हैं dementia के as we speak. Annual incidence is 77 lakhs every year all over the world, of which 60% are coming from developing countries or from middle low income countries. Alzheimer's 70%, as I've already said. Major causes of disability and dependency among older population, and it is going to assume epidemic proportions in next 10 to 30 years. By 2030, this is 75 million, and by 2050, almost 135, almost 3 times what we have number of patients now. So most contribution is going to come from the developing countries, as we are going to age, along with better quality of life and better financial status. In India, we don't have exact statistics, but it understood that we have a more aging population, so problem is going to increase further and further. So these are the different types of dementia. I'm not going into the details. Suffice to say that Alzheimer's disease is the coolest of them. The decline happens very, very slowly. But the vascular dementia is very fast. There is a step ladder type of form. Similarly, Lewy body dementia, there is a slow process, but lot of fluctuations. Then there is...
Another 5 minutes, please.
No, sir.
Your time is up already.
No, sir.
Why, sir?
Anyway,
5 minutes.
I will, sir, try to, as much as possible. Neuropathology of dementia, basically there are 3 main scenarios. There are alpha-synucleinopathies, amyloidopathy and taupathy. These are the intersecting circles we can see. They all interact with each other. For example, the patients who have Parkinson's disease, they can have amyloidopathy and alpha-synucleinopathy. Those with Alzheimer's disease, they can have amyloidopathy and taupathy. This comes into being into what are the biomarkers for cognitive impairment. So these are the basic risk factors for dementia. It's not only the genetics. The apolipoprotein E4 is the worst genetic subtype. But apart from this, there are other risk factors like low education, overweight, blood pressure, vascular risk factors, and all other factors. I will not go into all the details because of lack of time. There are changes in the neurotransmitters in dementia. We know there is a decrease in the acetylcholine, increasing glutamate, and decreasing serotonin and dopamine. And this is the classical hallmark sign. There is amyloid deposit outside the cell. This is classical for Alzheimer's disease, amyloid plaques. And then there are neurofibrils within the cell cytoplasm. These are the tau proteins. So these 2 are the main hallmarks. Apart from this, there is brain atrophy. So these triad, you can see how the brain cells shrinks, how the ventricles becomes more prominent. These 3 are the main reasons. Same thing again being highlighted in a bigger way. I will go to the next slide. This is what results. This is post-mortem. So the main dementia biomarker, this is for research and as well as for in future, what we have not seen what's going to happen. But all the new modalities, but there is no fun treating only patients when they have gone into severe dementia. We have to treat them when it is early dementia or it is in mild cognitive impairment. So the important biomarkers are, there is demonstration of amyloid and tau deposition as PET scan, which is known as amyloid PET and tau PET scan. There is a reduced levels of CSF amyloid beta 42, and there is elevated levels of phosphorylated tau. This is more significant as compared to amyloid. Then also there is hippocampal and temporoparietal atrophy on MRI. There is temporoparietal hypometabolism on FDG PET. Genetic risk factors are already alluded to. This is the scan. So you have normal persons also, they can have amyloid. But not all amyloid patients, they have Alzheimer's disease. So this is amyloid scan, positive, as you can see here. Tau, it is positive. This is a normal person with amyloid absent, normal person with amyloid present, but still not Alzheimer's. Alzheimer's is when a patient has amyloid as well as tau together. In fact, we see the tau is more specific for atrophy as compared to amyloid. So the dementia diagnosis is mainly clinical. So first, history. First is history, activities of daily living. We'll just skip this fact because this is understood. The common symptoms, which I've already said. The signs are usually absent in proper dementia. If there are signs, we have to look for focal sensory-motor deficit structural causes like tumors, NCC, tuberculosis, SDH, or Parkinson's. This is what we see on the physical examination. We have to go for such tests as mini-mental status examination. The cutoff above 21 is mild dementia, 10 to 20 is moderate, less than 10 is severe. Clock drawing test is about 93% specific for Alzheimer's disease. This is the MMSE. This is the clock. This is all these are Alzheimer's disease patients in different stages. This is a MOCA test. So diagnosis is mainly clinical. Neuropsychological battery helps us. Routine investigations just to rule out the treatable causes and those dementia which are fast. We must rule out brain tumor, SDH, and non-pressure hydrocephalus as causes of dementia. These are the treatable list. Highest among them is depression, endocrine disorders, metabolic disorders, eye and ear disorders, because these are easily treatable. And tumors, toxins, infections, alcohol. So rapidly progressive dementia, as I said, dementia is a slow process. It takes 5 years to 10 years for it to worsen. But if the person gets demented within the span of 6 to 4 weeks or 6 weeks, then we have to look at either infections or autoimmune process or malignancy or paraneoplastic or toxic metabolic. So management is treatment of the primary pain. We have to treat underlying disease process.
Could you please come to the recent advances part?
Yes, I'm skipping the slides. Yes, last. So these are the principles. So treatment of the etiology. These are the 4 main drugs: donepezil, galantamine, and rivastigmine and memantine. Behavioral and adjuvant management. These are important. There are other alternative standard therapy like behavioral therapy, DLT, and reminiscence therapy and validation therapy. This is the alternative therapy like art, music, activity, and complementary therapy. Then there is cognitive behavior therapy, interpersonal therapy. The patient care tips, I will skip these tips. So another part is, apart from treating the patient, we should treat the caregivers. There are groups which can be formed. So the main medical advancement as was the monoclonal antibodies, aducanumab, which was introduced last year and approved also, but there are lot many issues. Costly therapy not available in India, recommended select patients only in the Western world. Lecanemab has been this year only approved. It is also a costly therapy. Just that it helps in reducing the memory and the deterioration becomes less in this group as compared to untreated group. And there are minor infusion related issues. There were a couple of deaths. And there was an ARIA, which is amyloid related imaging abnormalities including hemorrhages and edema around it. This was the approval. Other novel therapies are nanoparticles for transferring all the drugs like donepezil, memantine directly through this nanoparticles directly so that they reach the brain and improvement happens. There is modulating the gut-brain axis, exosomes, and neuromodulation. I will come to this. TMS therapy in dementia. This we have. Transcranial magnetic stimulation is non-invasive brain stimulation technique. High frequency technique more than 5 Hz has effect on the brain plasticity mechanisms. It modifies neural pathways and circuits as function of both internal and external inputs. There is a promising, safe and non-invasive intervention. Increase in the MMSE scores has been documented. And though still we have a lack of agreement, so it is not FDA approved, but it reduces the dementia symptoms. It is a non-sedating technique, relatively painless. As such, TMS is approved grade A level for neuropathic pain, depression and hand motor recovery in acute stroke. This was the meta-analysis in which a personalized care has been found to be very useful. So to conclude, this is my last slide. There is a progressive memory loss and cognitive impairment with aging. Mild cognitive impairment can progress to dementia at the rate of 10 to 15% per year. Dementia diagnosis is clinically aided by suitable investigations, especially the treatable causes has to be ruled out. We should be prepared for dementia coming as our population ages. Dementia is a great socio-economic burden on the caregivers in particular and society and country in general. Tremendous advancement in understanding the biomarkers of dementia and impact on disease progression, diagnosis and therapeutic is still ongoing. We are still not come to the end. We are just the beginning process. We are understanding the process. Still there is no cure for dementia. We are still only supportive treatment, but basically in the whole day of life, as we are born, the child starts crawling. Dementia is the sunset of life. So we should look at it, make it more grand and acceptable for the families in particular and society in general. So there is exciting new molecules and technologies being used to improve the quality of life of patients and caregivers. Not only for the patient, we have to think of the life of the caregivers. So with that, I will end my talk. Thank you for your patient hearing. Questions? Okay. Thank you.
We'll have the next talk now, and question answers will be at the end of both the talks, but for one talk at a time.
Thank you, Yogesh. That was a wonderful talk by Dr. Sanjay Chaudhary as usual. So our second topic is regarding neurocritical care, and Dr. Arnab DasGupta. Please come. So presently he is a senior consultant at Department of Critical Care and Neuro Anesthetist at IBS Hospital since September 21. I won't say past history, but would say he was a consultant, senior consultant at the Department of Critical Care Anesthesia at the Fortis Hospital, Noida from 2016 to 2021. And he has done his MD anesthesia from AMCH. So he's going to talk about neurocritical care. I'd love to listen to him. Dr. DasGupta, please.
Thank you.
Am I audible?
Yes.
So good evening, everyone. Thank you for the warm introduction, sir.
Take a mic is on, but keep close to your mouth.
Okay, warm introduction on the rocks.
Okay. So I think I'm facing mild dementia as far as point out. So set the bar very high. I was with Fortis Neuro Anesthesiology, and before that I was in Max Sakit. So I'll quickly go through the slides. So introducing our neurocritical care unit. This is basically about a patient profile. We have all a mix of patients, mostly from neurosurgery and a lot of neurology patients, and a lot of do a lot of neuro rehabilitation also. So we have a lot of post-op care patients. Most of our post-op care patients are either neurosurgical or orthopedic surgery. We do a lot of TKRs and hip replacement surgeries. And then we have the usual set of sepsis and septic shock and community acquired pneumonia and UTI cases in this patient background. So, two books that I would refer to. One is the Checklist Manifesto by Dr. Atul Gawande. It is about improving healthcare and is bringing about the safety considerations, the airline industry and other things into the critical care practice. So, I'll be speaking about most of the things that these are all small things that I'm speaking about. Not when I joined this hospital, I found that it's an open ICU structure, and I do not really interfere with most of the medications that our primary consultants take. But even without that, there is a lot of things to improve when it comes to delivery of the services. So you might have come across this 1985 paper that in an ICU, on a day, there are 178 average interactions where errors can take place. And if you can bring down those things by even a small number, then patient safety can be improved. So this is an approach that SCCM uses, ISCCM uses, and we have integrated this in our daily notes. So twice in a day, this mnemonic is part of our daily note. So how many of you are using FASTag bits in your daily rounds? Other than critical care people, are you using it in your daily rounds, something like this? So it's a small set of mnemonics where FASTags, F is for feeding, or the IV fluids that we give, the consideration for that, and here we follow the ASPEN or the ASPEN guidelines and the Indian Society of Physiology guidelines for fasting. For example, for a patient going for surgery, we allow clear fluids up to 2 hours before surgery. And in ICU patients, other than the patients who are crashing or who are undergoing resuscitation, we start rights to feed right on day 1. But we do not start the entire expenditure. We start with around 25 to 30% and then go up over the next week or so. So for analgesia, we have practically eliminated opioids in the post-operative period, and even in analgesic we use other medications to keep the plane of anesthesia light, and we use something like dexmedetomidine, and we are using a lot of ketamine in our practice nowadays, so that our patients are mostly neurology patients. The neurologist or the neurosurgeon should be able to assess the GCS of the patient whenever he or she wants. There are only 2 cases when we use deep levels of sedation. One is in the raised ICP scenario, and one is when there are refractory seizures. Then for thromboprophylaxis, we use a lot of scoring. The rest of the mnemonics, if you go, F is for feeding, A is for analgesia, S for sedation, T is for thromboprophylaxis, which we consider from day 1. Since it's a neurosurgical, neuro anesthesia, neurology unit, most of our patients get only pneumatic pumps, DVT pumps. And the situation of using pharmacoprophylaxis is rather limited. Then this approach, we use it as a checklist in all our rounding notes. On the de-escalation part of antibiotics, we try to optimize. Right, in an ICU, we usually get these MDR organisms, and they are, as you all know, that they are very difficult to treat. We usually get a lot of gram-negative organisms. So we can improve the, if you look at this, so the antibiotics can be of 3 types. They can be concentration dependent, they can be time dependent, or they can be concentration and time dependent. So depending on the type of antibiotics, for example, aminoglycosides or metronidazole or fluoroquinolones, when they are used, we give them as a bolus. But other medications which are time dependent, like the cephalosporins, the imipenems, the carbapenems, we give them over half the interdosing period. So if we are giving meropenem thrice daily, we give it over 4 hours. That is called the extended dosing interval, because then you have the maximum area, the concentration above the MIC value, and we get better results with that. This is a slide from a 2016 Bhattacharya's article on antibiotic-associated encephalopathy. So antibiotics are double-edged swords. They help with infections, but in a neuro unit, they can be either causing type A1 antibiotic-associated encephalopathy, which is usually more of seizures, or more of psychosis. So we want to de-escalate early, and that's why we use that FASTag bits mnemonic. We use measures like procalcitonin fall by 80% or a value below 0.5 to rapidly de-escalate antibiotics and get the patients off antibiotics as fast as possible. So this is another thing that we are trying to introduce. SCCM has its pain, analgesia, agitation, delirium, immobilization, and sedation and sleep guidelines. So for the patient who is not able to tell us that he or she is in pain, we use things like BP, SNC, but these are different scoring systems that we use to identify and treat pain. Similarly, for agitation, we use the RASS scale. I'll show the RASS scale in the next slide. And the idea is to keep the patients at a level of, just barely. I'm just doing the next slide. This is the Richmond Agitation Sedation Scale that we use in ICU, and our target is 0 or -1. So if I'm doing a good job in my talk, then you will be probably at 0, but if I'm not really doing well, you might go to -1 or -2. So most of the time we achieve this 0 or -1 level with drugs like dexmedetomidine. Or sometimes we use a combination with ketamine also with it, which is now coming back into our ICU practice. For IV fluid administration, clinical signs are good, but many times our clinical signs are wrong. And we use goal-directed fluid therapy, and we use early enteral feeding. So most of our patients are off IV fluids by day 3 or 4 in the ICU. So we switch over completely to enteral feeds as far as possible. And when possible, we use dynamic indices of fluid status, where if the patient is ventilated, there are indices that are available from our monitor, from our arterial waveform analysis, or by ultrasound using the IVC diameter, which gives us an idea of whether the patient is actually volume deprived and in need of fluids. For the fourth point, thromboprophylaxis, DVT prophylaxis. For our surgical patients, we use a Caprini coding, and for ICU patients, we use a Padua coding. And in most of the time for DVT prophylaxis, we use DVT pumps. And when our neurosurgeons allow us, and when sir allows us, we use drugs like Zane, enoxaparin, or we switch over later to apixaban. So regarding in the nutrition, the last 1 year or so since I've joined, I've practically not used TPN. We stick to initiation of right tube feeding within the first 48 hours, and we try and reach the total expenditure targets by 7 days. So if we increase these calories gradually, we prevent the refeeding syndrome and imbalances such as hypophosphatemia, hypokalemia, hypomagnesemia, and thiamine deficiency. I'll just put this slide. Since it's a neuro hospital, we have to manage the ICP, and we manage it on different levels, going from tier 0 to tier 1 to tier 2, and very rarely we can go to tier 3. Tier 3 involves either hypothermia or barbiturates coma, which is seldom done in critical practice. But for tier 1 and tier 2 therapies, if the patient needs surgery, then our neurosurgeons are there to help us. Otherwise, we have other means of reducing the ICP, which we are all aware of. So I'll just skip this slide. In an ICU, especially in neuro ICU, not all fevers are caused by infection. So we get a lot of cases of PSH. It's paroxysmal sympathetic hyperactivity, which is identified on a scale using a number of factors, like a patient could be having profuse sweating, tachycardia, tachypnea. Sometimes the minute ventilation on the ventilator goes up to 20-30 liters. Sometimes the heart rate goes to 200. Fever goes to 104, 105. And they respond to simple if we manage it well, and if we rule out infection by using other markers like TLC and procalcitonin. Then dexmedetomidine, propranolol, we use these drugs very frequently, and sometimes we use morphine to deal with the episodes of things. And in the neuro ICU, we have a lot of electrolyte imbalances, including hyponatremia and hypernatremia. But one thing that we are facing very frequently is magnesium deficits. And magnesium helps us. Magnesium supplementation is an intracellular ion, just like potassium. So even if the levels are normal, we often supplement. One of the things that helps a quick patient in getting them out of ICU is early mobilization. And for this, you can refer to this chart, where whenever the patient has a RAS level of 0 or -1, and whenever we can, and the patient does not have any contraindications to mobilization, we try to get the patient mobilized in bed passively, or to the edge of the bed, or out of the bed as early as possible, and to get them mobilized as early as possible. Then, most of the ICU patients that we come across, they have sleep deprivations, and there's a reversal of the sleep cycle, and optimization of the sleep cycle also plays a crucial role. We avoid benzodiazepines when possible, and we try and use other strategies such as light and noise reduction, and sometimes we use melatonin. nowadays it is not possible to do any ultrasound, any ICU care without leveraging the power of the ultrasound. So ultrasound is used in everything in the ICU, including lung ultrasonography, where we have the blue protocol, then the fast scan in trauma, and then for every procedure that we do, if we put it using an ultrasound, it becomes much safer and the number of attempts goes down. So central lines, arterial lines, any procedure that happens in ICU, we can use the ultrasound for that. So whether we are doing a good enough job or not, for that there are a lot of ICU indicators. These are some of the indicators that we use in our general ICU patients, like iatrogenic pneumothorax or length of stay. Now in a neuro ICU, the length of stay is usually higher, and the ICU readmission rate and the reintubation rate are often higher, because we often give our patients a trial of extubation in trying to protect them from tracheostomy. And then there are some, as we develop this neurocritical care unit, there are some indicators that we want to consider which are neurospecific, such as for every admission, let's say a stroke patient gets admitted to the hospital, for every patient we should have the NIHSS score on file. So these are the things that we are targeting in future. For example, a patient in status epilepticus should get benzodiazepines within 20 minutes of entry to the hospital. So these are some of the things that we are planning to implement in future in order to improve our delivery of services. So I think I will conclude.
Kantor would like to add something to what you said. Go ahead.
Okay, so as a neurosurgeon from the same hospital, I'd like to add two things to Arnab's talk. Number one, PSH, what he talked about. So paroxysmal sympathetic hyperactivity. We see that quite often in severe trauma or severe stroke cases, which probably people have been neglecting earlier. And the management strategies are totally different. You don't require too much of antibiotics and aggressive therapy for infection. No, the patient is dealing with PSH. That's one thing which we always keep a high index of suspicion. Number two, what we follow is early mobilization. So any patient who is semi-conscious, when you make him sit and his feet touch the ground, his proprioception regains. That is the best thing for regaining his consciousness. That is a very important thing which you can try to practice. It's only.
Thank you.
Thank you.
So Dr. Sandeep, can you throw some light?
No. I mean, I agree with all of you for whatever you said. The thing is, I just want to lay the emphasis on ultrasound. Ultrasound, which probably we are using left, right, and center now in the ICU. Ultrasound is a new stethoscope. We use it, especially in neurocritical care. We use it quite often.
Can you be a little louder?
Yeah. So ultrasound guided ICP measurements, which we do routinely in our ICUs, which we do that. Now you did talk about targeted. Yeah, we did talk about TTI. We targeted temperature management in the ICU. So that is very, very important, because earlier we used to say that we should go to hypothermia, but now we say that 34 to 36 is the ideal temperature. Because I mean, there will be a lot of studies regarding that, and it improves the outcome. Even in the post-arrest patient, it improves the outcome. More than that, I think your fast size approach, BID, that is the most important thing. I mean, that solves a lot of problems, not even in the neurocritical ICU, even in general medical surgical ICU. You can follow the daily goals, therapy. It takes in a lot of things. Antibiotics, yeah, de-escalation. So that is why we believe in antibiotic stewardship now. At least twice a week we have stewardship round with our ID specialist, and we discuss all the antibiotics, whatever needs to be de-escalated. I mean, we don't rely specifically on the biomarkers like procalcitonin. We just, I mean, if there are no signs of any infections, we should probably, because ultimately we end up with MDRs in the ICU. So that is what what we do. More than that, I think you have covered, but general ICU care is very, very important. And talking to the family members, that is the most important thing, because you have to make sure that you talk to the family and document your progress and document your counseling of the family. That is most important. Yeah. Thank you.
Are you using symbiotics?
Yes, we do.
So I would just like to add one thing. So I'm a neurosurgeon. I'm basically a person with a knife, but still I'm aware of the fact that entire research right now is focusing towards microbiome. Gut bacteria, they are actually very important in patient outcome as well as a normal human being living his life peacefully, right? So what Arnab will tell something about microbiome.
That was
No, hold on.
the input of.
We need to probably talk about Dr. Sanjay Chaudhary. Yes. About the dementia.
Yeah. It was a masterly presentation on dementia, the various causes, the various stages, and the features in the various stages. Among the recent advances, you talked about the TMS and monoclonal antibodies. About TMS, I want to know, are there enough studies about it? How much it costs at your place? And how do you decide the patient has improved?
That's a difficult question, but yes, TMS as you hello?
Yeah.
Yes. So TMS basically, there lot many studies have been done.
सर आवाज नहीं आ रही नहीं पास मैं नहीं सुन रहा तो पीछे वाला क्या सुन रहा हूँ
ठीक है. I think that's not on.
Hello? Yes. So TMS actually is not FDA approved. So it is only in certain selected cases that in whom we have a specific target. For example, speech, like cognition, memory impairment, and those, especially those whom we get them at an early stage. Only in those cases we selectively tell them, because it is not officially approved, so we have to tell them that it benefits, this is costly, and it's quite costly. It depends upon three things. One thing is the session timing and how frequently we are doing it, and it depends upon how long he has to continue.
Sir, are there any studies about other reasons when TMS is used, like depression?
Yes. So TMS, let me say our second question. So TMS is approved for neuropathic pains. It is approved for motor depression and motor weakness in the upper limbs. So in motor, there it is post-stroke especially. Apart from this, OCD, obsessive compulsive disorder, also it is approved. But in dementia, it is not approved, but it has been studied. There is a meta-analysis in which about 13 trials they have been synthesized, and they have found out, because every center does it his or her own way. Some stimulate over the left parietal region, some people over the occipital region. So depending upon the modalities, upon the duration, whether it is single, whether it is paired, whether but all we do, so pattern wise it changes, so it cost factor also changes. So,
sir, if we send a patient, how much money he should expect to be providing?
So there are two things. Number one, TMS, as sir rightly said, has been approved by US FDA for various conditions like OCD, depression, even in ADHD and autism, to be very frank, right? Now there are two things. TMS at our hospital is totally different from TMS done anywhere in the world. There are only 5 centers in the world which are doing TMS like we are doing, because TMS is practiced on a wider area in cases of like OCD or depression or ADHD, that you focus the entire lobe of the brain and you give stimulation to that. Here what we do infinitome, we do MRI which delineates those tracts which are responsible for that problem, right? We identify them, we get the electrical current values, and based on that, we only specifically give TMS to those tracts at the different levels. So the result is different. Yes, it is giving. We have patients of autism, we have patients of depression, ADHD getting beautiful results. And
approximately cost, I can say, is about 3.5 lakhs for a 20-day course.
okay.
So it is approximate.
So what happens?
Plus minus, we can individualize.
So what happens that when we take talking about the outcome is basically by the questionnaire, right? Number one. Number two, we can also do MRI, the same MRI which is showing tract hyperactivity. You can repeat it after the completion of the course. You will see the difference in the tract electrical currents.
Dr. Paul sir,
No, it does not.
Dr. Paul sir, Dr. SP Singh sir has a question on the first speaker.
HP Singh का तो बात
Let us complete.
No.
Okay.
Listen. Suniye sir, please.
So very important topic.
From Goa.
Yes, sir. Not Goa, sir. Delhi. Sir, after 50, 60 or 70, everybody having this problem. चाहे हम हो, डॉक्टर जो भी हो, everybody is passing through this process.
Yes.
मैं भी कहता हूँ अभी सर आपका नाम क्या है मैं चाहता हूँ मुझे नहीं पता सर थोड़ी देर में आ जाए ठीक है. Now question is the person who are having high wealth करोड़ों अरबों रुपए होते हैं उनके पास में उनके बच्चे भी होते हैं जब धीरे धीरे वो वेट बढ़ते पहुंचे 60-70 मरने की आजाद में है तो क्वेश्चन आता है कि वो बिल किसको लिखें. क्वेश्चन है कि एमसीआई के पेशेंट बिल किसको लिखें. अब बच्चे भी परेशान अगर वो बिल लिख
Preventive medicine which is causing us to look for those cases of aging सबको होना है सर. एजिंग के साथ कॉग्निटिव डिक्लाइन सबको होगा लेकिन जब तक कॉग्निटिव में इम्पेयरमेंट नहीं होगा तब तक उसको ट्रीटमेंट दे नहीं सकते हैं ना. एक नॉर्मल पर्सन को थोड़ा सा नाम किसी का भूल गया उसको थोड़ा ट्रीटमेंट स्टार्ट कर देंगे हम. सो वी आर सेलेक्टिंग एमसीआई एज प्रॉपर patients on whom we can treat and we would like to see how they can be prevented from being converted to ADI.
So their bill is valid.
Yes. MCI is allowed. Screening is very important and it has to be not one day process. आज हमने चेक कर लिया ठीक है तो मतलब ये नहीं कि 6 महीने बाद आप डिमेंशिया में मैंने कहा 10 to 15% of patients who have MCI will land up within a year of in fact almost 50 to 80% of patients of MCI जो आज हैं वो कल कन्वर्ट हो जाएंगे इन डिमेंशिया within a span of 5 years. So 5 साल तक वेट नहीं करना है. MCI या किसी ने आपको कह दिया कि आप है MCI तो आपको बिल बना लेना चाहिए तब तक वैलिड. MCI persons are valid because they don't have dementia as yet.
So my second question.
Legally approved.
Practicing it has to be a board of 3 doctors at least. It cannot be one. और तो पैसे देकर बनवा लोगे?
नहीं सर आप
पैसे देकर बनवा.
Sir, my second question.
Yeah.
Yes.
Those who are having high wealth but they are unpढ़. पढ़ना लिखना नहीं आता, साइन करनी आता, कुछ नहीं आता. जब मरने की स्थिति में आते हैं सर वो, तो उनके बच्चे अंगूठा लगवा लेते हैं. कितना वैलिडिटी है सर?
वैलिड नहीं है सर. क्योंकि इसलिए क्योंकि हम लोग जो असेसमेंट भी करते हैं ना माइल्ड कॉग्निटिव इंपेयरमेंट का डिमेंशिया का इट हैज टू बी इनग्रेन्ड विद दैट मिल्यू. मतलब एक जापानीज को आप हिंदी में सवाल पूछ के उसको तो डिमेंशिया हो जाएगा. तो इट हैज टू बी इन देयर कॉन्टेक्स्ट. वी हैव टू आस्क देम दोस क्वेश्चंस व्हिच दे आर यूज्ड टू. जैसे एक बंदा कुम्हार है तो उसको बर्तन के बारे में हमें पूछ के उसकी डिमेंशिया है कि नहीं पता करना पड़ेगा. एक बढ़ई को उसके बारे में पूछना पड़ेगा. जो किसान है तो किसान के बारे में आप पूछेंगे किसानी के बारे में अगर वो बता देते हैं देन वी से कि हाँ डिमेंशिया है कि नहीं है. तो डिमेंशिया का लेवल हम तभी किसी को लगा सकते हैं उसके लोकल सोशल कल्चरल एथिकल उनके जो मिलू है उसके अंदर में घुस के उनके स्कोरिंग उनके जो पैरामीटर उसी एज में आके कितना स्कोरिंग हुआ है उसके हिसाब से भी लेवल करते हैं कि ये डिमेंशिया है कि नहीं.
सर
Thank you, sir.
थैंक यू सर.
Dr. Sanjay sir, at the age of 33 years sir, at times when I was in a marriage function, I used to forget the name of the function I was just about to introduce to my wife. So I उस टाइम में गूगल नहीं होता था सर. मैं 88-89 की बात कर रहा हूँ. तो मैं ये पूछ रहा था सर आपसे कि वो नॉमिनल एफेजिया जो होता है जब आप नाम भूल जाते हो इज दैट अ प्रीकर्सर टू डिमेंशिया. मैं अभी तक डिमेंटेड नहीं हुआ सर.
नहीं है डिमेंशिया नहीं है. ये मैं कहना चाहूँगा इसलिए मैंने मेमोरी का शुरू में बताया था. अब इमीडिएटली जो मैंने आपको बताया कुछ और आपको मैं पूछूंगा ये है इमीडिएट मेमोरी. ये रिकॉल का है. ये मेमोरी का पार्ट नहीं है. इट इज ऑफ अटेंशन. आप कितना ध्यान से मेरी बात सुन रहे हैं उस पर डिपेंड करता है. इट इज अटेंशन इशू. उस समय की बात ना उसमें रिलेटिव पूछा है क्या बोल रहा है उसमें. आज तो वो याद है नहीं. आज अगर वो चीज़ है आपको बहुत पुरानी बात आपको इम्पोर्टेंट नहीं था तो वो याद नहीं रहेगा. लेकिन आपके स्कूल में गए थे आपके जिगरी दोस्त कौन था आपके पड़ोस में कौन रहते थे वो सब याद है. ये डिमेंशिया नहीं हुआ फिर आपका. पुरानी बातें भी याद है और आज की बातें भी याद है.
क्यों होता है
वो इसलिए अटेंशन आपने ध्यान नहीं दिया. आपके मन में बहुत सारी बातें. ह्यूमन बीइंग्स कैन मल्टीटास्क. मैं आपको देख भी रहा हूँ, माइक्रोफोन भी पकड़ा हूँ, वो फोटो ले रहे हैं कि नहीं ले रहे हैं, खाने में क्या बन रहा है, ड्रिंक्स क्या लेना है, सब चीज मालूम चल रहा है. So I may not pay attention to your question. I may pay attention to what she is doing, what he is doing. So that is different. So जिसमें आपको इंटरेस्ट होगा वो चीज आप कभी नहीं भूलोगे.
सर ऐसा
That is different.
Sorry to interrupt. मैंने पढ़ा था एक किताब थी मैकग्रेगर सर्जरी की हमारी, उसमें एक फैक्ट लिखा था ग्रेज एनाटॉमी को काउंटर करते हुए. ग्रेज एनाटॉमी होता था पूरा हमारा कि at a time human brain can remember 1 lakh facts approximately. If he is to enter new facts, it has to kick out old facts.
Or correlate.
Yeah.
तो मतलब अगर मुझे नाम याद नहीं आ रहा सर आपका, है ना, मैं और घर पे जाके तो डॉक्टर विकास से बात कर रहा था यार, यार बड़ा अजीब लगा मेरे को. मतलब
सर मेमोरी के 3 कंपोनेंट होते हैं, ठीक है. एक होता है रजिस्ट्रेशन, एक होता है रिटेंशन, एक होता है रिकॉल. सर बताइए तो आपने रजिस्टर कैसे किया, दैट इज मोस्ट इंपॉर्टेंट.
ओके, डू वी हैव सम मोर? जस्ट अ मिनट सर, जस्ट अ मिनट. डॉक्टर नरेंद्र
बात करते हुए दोबारा बताओ जरा, रजिस्ट्रेशन ये दोबारा बताओ ये बातें, ये आपने बड़ी अच्छी बात बताई है सर.
सर रजिस्ट्रेशन मतलब चीजों को रजिस्टर करना, रिटेंशन मतलब रिटेन करना, और रिकॉल जरूरत पड़ने पे वापस रिकॉल करना कि हाँ ये था,
तभी मेमोरी बनेगी.
हाँ तभी पूरी मेमोरी के सर्किट कंप्लीट होते हैं. अगर आपका रजिस्ट्रेशन ठीक से नहीं हुआ तो आप रिकॉल नहीं कर पाओगे. दैट्स व्हाट सर इज सेइंग. लीव असाइड सर.
Sir, just a minute. Before I come to Dr. Kalra, there is a very intelligent person here, fellow of the Royal College of Physicians, Dr. DasGupta.
Yes.
Thank you. Just a simple question. How much is your per day cost in the ICU for the basic conditions?
Cost factor-wise, approximately.
Yeah.
For in a patient who is on ventilator, obviously it is around 40 to 50,000 per day. And those who are non-ventilated, 20 to 30,000.
And Dr. Jitendra Saxena, my batchmate, has a question.
Sir, my question is for the critical care specialist.
Yes.
Generally, जब बंदा ICU में जाता है, then major concern is, at least for the patient की कभी tendency ये बाहर निकल के आएगा नहीं आएगा. And infection is the biggest challenge when the patient is in ICU. Whether it happens because of the ventilator itself causing kind of a pneumonia, or there is a catheter inside, urinary tract infection, or maybe some fungal infection, stress ulcers. So what are the hopes that you will give to a patient attendant that the patient is in ICU, that he is going to come out in spite of so many challenges, the ulcers, the infections, the fungal infections, the bacterial infections. So how do you really attendant of the patient, how do you handle the attendant of the patient?
See, first and foremost, it is very important to tell the truth. Don't lie to the patient's relative. That is the most important thing. And every day, every shift, at least once at a time, once in the shift, we must speak to the relatives. That is the most important thing, because if you're not talking to the relatives, they will not be at ease, because they will have lots of questions. Plus, make sure that you're only speaking to one person at a time, because there is a dissemination of information, and there is also a lot of information is lost in translation. So speak to only one person who is responsible, who's the responsible caregiver of the patient, and delegate his responsibility to speak to the other relatives. The information from the other relatives should come only from that person whom you have designated. Because if you're talking to 10 different relatives, there will be a lot of chaos and a lot of confusion. So speak to the one person, talk to them daily, document, or maybe in some cases you may have to record the conversation which you are doing with the relatives of the patient, because that is what which is going to save you in the legal court.
That is very important. Very well said. Just a minute, Dr. Vikas. Dr. Arnab, of all the patients who are ventilated in your setup, what percentage of patients are you able to return to a useful life?
Okay, very wonderful question.
That was for the second topic. Let's complete the first one.
Sir, we have completed the first
No,
topic.
we haven't.
Just a minute, sir. Answer the question.
as sir said, that first of all we have to be very honest with the people. Heart disease के लिए suppose there is a spontaneous ICH. For that there is an ICH scoring. Today morning I showed a patient. Mike, please. Today morning there was a patient with spontaneous ICH. I did the ICH scoring. It was 3. It shows a mortality of 72%. 72% mortality मतलब 100 patient में 72 will die, 28 will survive. This is, I put it forward. लोग बेवकूफ नहीं है, हर कोई आजकल गूगल कर लेता है. If you are honest with them, they appreciate your effort. जितना भी खराब न्यूज़ हो कि नहीं हो, if you like for Hunter for SH, अगर stage 3 है, stage 4 है, whatever the grading, if we communicate honestly, for sepsis we communicate the surface coding once we have the thing. So when you are honest with that index, ventilator, most of our ventilator patients either get extubated or get a tracheostomy. Very few die. But that we explained right at the beginning. In fact, problem तब होता है जब हम लोग छुपाते हैं. If we are not honest with the patient, और patient का socio-economic status उतना नहीं है कि वो समझे, then we have problems. But for most patients, if you guide them to simple patient education materials, Mayo Clinic का, Cleveland Clinic का, you just point them to the right sources from ये most of them are very happy and they accept it.
So what you told us is that 72% people will die.
No, sir, that is only for ICH.
Sir, sorry, that is for specific conditions. Let's not generalize it.
No. So answer my specific question. What percentage of your ventilated patients you are able to return to a useful life?
Answer this question. It depends on the patient. For some patients, there is satisfaction even if their parents are alive. बहुत लोग बोलते हैं सर हमारे पास है इतना ही काफी है. तो if you are able to do a tracheostomy and they are M5 or M4 at home, they take it. They are happy doing the seva of their parents.
Okay, Dr. Chauhan, I'll answer this question. In our ICU, around 80% of people, let's say on last 3 months, we have been able to get off ventilator in home care.
Good. Okay, I think Dr. Kavda sir has questions.
फ्रेंड्स, आज इस हुजूम में मैं अकेला हूँ जो दोनों तरफ से आया हूँ. स्पॉन्सर्स की तरफ से भी आया हूँ और अटेंडेंट्स की तरफ से भी आया हूँ.
You work in IPS, sir?
I have joined IBS recently.
सर मेरे को नौकरी लगवाता है.
तो मैं इसलिए कह रहा हूँ कि मैं सरवाला भी हो सकता था पर मैं बना नहीं. सब मेरे 3 सवाल हैं छोटे.
मेरे भी 3 हैं.
सब biomarkers of dementia. What is the specificity and sensitivity?
Biomarkers of dementia में there are 3 different types of. One is the CSF. In CSF, they say if there is beta amyloid 42, if CSF level goes down, then that is suggestive of Alzheimer's disease. Second thing is if there is a phosphorylated tau, and best is if they do go hand in hand. The sensitivity and specificity goes for Alzheimer's disease to be more than 93%. If added with this, then there is a superimpose. We do nowadays PET scan. If there is amyloid PET, as I showed in the diagram, if there is amyloid positivity along with phosphorylated tau, then again it is 80 to 90% sensitivity and specific for Alzheimer's disease. Beyond this, there are other markers, like in MRI there is atrophy of parietal, but that is not specific. That is hardly, I would say, 40 to 50%. Next is we do sometimes FDG PET. This is again if it is in the temporal and parietal region, then it is again 50 to 70%. Because so many other diseases also have similar sensitivity. But if there is a reduced beta 142 and raised tau, phosphorylated tau, along with PET, then it is confirmatory, almost I would say 93%.
Sir, for those who are making noise from the back benches, let me say, even if मैं गले से हूँ, फिर भी मैं आपको जरा लाइट कर दूँ ये कहते हुए कि एक तरफ तो हम याद भूल जाने की बात कर रहे हैं एक वो गाना है याद आ रही है तेरी याद आ रही है. Is it also something anti-dementia or what is that?
Yes, in fact, in the alternative therapy I had said there is the music therapy.
Yeah.
In fact, anything which keeps the patient busy, we have to stimulate the patient's mind audiologically, visually, and by asking him to ruminate over his past memories. We ask the patients to go through the old albums, old photographs, old persons. More you talk to your friends, more you talk to your people with whom you can correlate with each other, that reduces the increase of dementia.
And you say micrographia was said to be a precursor of Parkinsonism. So is it also related to AD?
No, Parkinsonism, they themselves can have dementia. It is Alzheimer's. They are in a different group, like they are alpha-synuclein group. They also lead to deposition of alpha-synuclein within the neuronal cells and leading to the cell damage and atrophy. They also have what it is more of a frontotemporal type of a dementia. Dementia can be of multiple types. Main classical types in Parkinson's, it is mainly frontotemporal, more of frontal executive decisions. They are involved.
Sir, my
less memory problem.
Last half question is, some people become abusive in their elder age, say about 80s or so. So are they also a part of dementia, or is it a behavioral only?
Yes. So behavioral changes, these are very important aspect of dementia. It is especially more marked in those patients who have frontal, because these are mainly frontal controlled behavior issues. So this mainly because not that they want to be angry, they don't understand that they cannot do without it. So they do it just for the sake of it. The inhibition on the frontal is not there. So that's why they do it. They're just like after taking more than the usual dose of alcohol, the frontal inhibition goes away. So you can even abuse your boss. You can talk to anyone or any person in any way you like, and you don't feel the remorse of it. So something like that.
Right. I would request Dr. Yogesh Pal sir to summarize the first part of the CME for us.
So that was a wonderful masterly presentation on dementia and various aspects, the causes, various stages and treatment was told very clearly. Sir, I have a question about monoclonal antibodies.
Yes, sir. Yes, sir.
They have some significant effects in the form of ARIA, which is specific to the monoclonal antibodies used in Alzheimer's.
Yes.
And one of the features is hemorrhage.
Yes.
And if a patient is already on antiplatelets or anticoagulants or has a bleeding diathesis, would you give monoclonal antibodies to such an Alzheimer patient?
Yes. So that is the main reason why last question or last year also he had asked me the same question. I said I will not give it. These were the reasons, because all of these approvals have come from stage 2 trials. Stage 3 trials, they have not been done before approval was given. These things come all when we do stage 3 trials. Then we see this. So I'm saying, sir, that's but they have approved it beforehand. So that is, they are allowed for any other center to give it. But point is, it is not available in India. Even in Western countries, not available at all centers. In selected centers, they are being only under trial basis. Only if they will be approved, then only will come into the commercial usage. So my take is, at such a cost, with such little benefit, it's only the MR and radiological and the PET improvement is there. Real clinical improvement was not there, and some people lost their lives due to such events. So, fingers crossed.
Thank you.
Maybe future will give us the clue.
Dr. Tulsi is absolutely eager to ask his wonderful set of questions. Dr. Arnab, you gave us a beautiful presentation of what you are doing. I want to ask you, what are you doing in IBS which other people are not doing? So, just for the gathering, what is your USP in neurocritical care? Please, can you just summarize it for us?
See, it's just a year that I have joined them, and we are in the process of setting up. When I joined, I was told that we are expanding into a 100-bedded hospital. So all protocols are not in place. We are just going one step at a time.
What is your USP, sir? Just elucidate. What is your USP in IBS, which is probably not there in Max or forte that we should look forward to?
Exclusivity, sir.
Maybe I will fill it for him.
Maybe. You don't have it right now. You don't have it right now.
Okay, Dr.
That's my deal.
He's too perfectionist to answer anything. There is a very significant coordination between critical care and neurosurgery. Arnab has a beauty of getting state-of-the-art, latest literature review for every damn thing he has, and he is after the patient till he gets him home. It's a lovely thing.
The personalized.
Yes,
Personalized medicine, I would say. So he gives his best to each and every patient. That is the most part, I would say, USP for him and for us.
Dr. Mangla has been dealing with a lot of critical care in Mulchan itself, being the head of pulmonology in Mulchan Hospital, and at times he has to involve critical care specialist, neurologist. One of my own patients who unfortunately died in Mulchan had to require critical care. Sir has a question.
You know, patients remain in ICU, especially for a longer time, for a long time. You know, they go through different phases of hypertension, high counts. Now your patient has improved, and suddenly you find that the counts have jumped to 27,500. You have done a bronchoscopy, it shows asymptomatic. Patient appears reasonably stable, the procal is not very high. What do you do?
Now, most of these MDRs, they will develop in a patients who chronically ventilated in the ICUs. So you have to identify whether it is a colonization or an actual infection.
You've done a ball.
You've done a ball. You got the positive culture, but it still may not be an actual infection. Just maybe a colonization. So you may not need to treat it unless the patient becomes hemodynamically unstable.
That is what I am saying. 2 days later, you find that the NORAD has started. Now you are losing 48 hours. That can count. Patient may die.
So
whether you can ignore this race count, just one second. Whether you can ignore these race count, and you have won a lot, and the counts have jumped from say 12,000 to 27,000, and next day you find they are 29,000. Procal is borderline. Whether you would start cholesterol in this patient, or you would like to say, let me watch till he becomes hypotensive again, and he dies. So what way it is, we have a very common problem in ICU.
I'll tell you. See, we don't treat the numbers in the ICU. We treat the patient as a whole. So we are not looking at the numbers alone. We are looking at the patient as a whole. We are not, at one point in time, you're saying the count is 29,000. But at the same time, we're looking at the vitals of the patient with the vitals. At any time the vitals become unstable, we have a very low, propensity to start the antibiotics. So it's not that we're waiting for the counts to jump to the next level and then we wait for the counts to start to the next level and then start the antibiotics. Right?
I agree. Once you have allowed the patient to go into
Sir, I have one question, sir.
The exact situation that you're describing, we have faced it 4 or 5 times in the last 2 months. The patient is not in sepsis. Patient has signs of infection in the chest. THC is rising, procal is normal. We have got away by giving only nebulization of cholesterol, 2 million units thrice daily, along with meropenem as a synergistic drug or ertapenem as a synergistic drug, even then when they were resistant in the culture. And we have got,
you are giving cholesterol.
We are giving cholesterol only nebulization, only nebulization. We are avoiding the systematic cholesterol. And we have, because Acinetobacter is a pathogenic bacteria and it is coming in the bowel culture. And we have faced this problem.
Once you decide to give cholesterol, might as well give a full dose. Otherwise,
the side effect profile is much like only with.
We have done enough of it, and I find I have been treating like you are delicate. I have seen that as and when you ignore them, you lose more patients than
they come back.
So might as well react.
So this strategy has worked for us.
I think need to talk about it. Dr. Kandru has a question. Our gentleman Jay Hari Vishnu has a question.
Nanomaterials are used for AD, and what is its future and outcome? Is it really, are we using this thing in IVS?
No, sir. Nanoparticles, these are still in the developmental stage. Basically, what they're doing is, ordinary drugs which we are giving by mouth, they have transporting them via nanoparticles so that it is easily available, so that the blood-brain barrier is not cut off. So the side effect profile, because most of us we know rivastigmine, donepezil, they have GI side effect, GI bleed. So those parts are taken care of, but it's still in developmental phase. It's not available in the market.
Another question. ApoE, again, is the UC marker of the Alzheimer's disease.
Yes.
This ApoE protein, you see, just see,
it is being done
in the CF for this thing.
And the ApoE is, this is done from the blood. ApoE level protein, it is done from the blood. So it is done. CSF may only tau, phosphorylated tau, and beta 140.
Actually, tau is already present in the neural cells. It is the phosphorylated.
If it is phosphorylated, ordinary tau is not important. Phosphorylated tau is significant.
Derangement of the mitochondria.
Yes.
That is why it is the hyperconstitution that we have free radical C formations. And that the degradation of this neuron status.
Within the cell, the neurofibrils, those are all tau.
Dr. Narendra Singh has a question, and then we come to Dr. J P S Tulsi, sir.
Sir, Dr. Chaudhary's question है, sir, practical question है, डेट स्कैन है ना, पहले हमारे यहाँ गैदरिंग है, अब डेट स्कैन हम स्क्रीनिंग के लिए करते हैं पार्किंसन डिजीज के लिए, इसके लिए पेशेंट आता है क्लिनिक में पूछता है, मेरा डेट स्कैन करा दो, तो वो सर मतलब what is the real time to do the DAT scan for to rule out
Parkinson's देखने के लिए कि confirm करने के लिए basically, but clinical practice के लिए नहीं, because Parkinson's is a clinical diagnosis. Only when we have a doubt, especially when we are starting some early Parkinson's drug therapy, then we need to go for that. Normal clinicians go, that is not for patient, not for the patient, it's for us.
I think some wonderful questions from Dr. J P S Tulsi, sir. Just to wind up this segment, 3 minutes we have.
Just 3 minutes, sir. So it's already 10:30. I haven't asked even a single question. Can I believe that?
Carl Lewis made history in less than 10 seconds.
Okay.
Yes, sir.
Sanjay Chaudhary, just 3 small questions.
Yes, sir.
Talk us through the DMD. This is disease-modifying drugs, as we know.
Yes.
We have had accelerated approval by the US FDA on 6th of January on lecanemab for mild cognitive decline.
Yes.
And to reduce amyloid beta plaques in early Alzheimer's disease. Talk us through the lecanemab.
Yes.
And the second question would be on the area.
Yes.
So what is area and what is the pathology behind the area? Talk us through that. And the third question is the recent biomarkers. Please, sir.
Okay, sir. Thank you, sir. Thank you, sir. You have asked really interesting questions. So, lecanemab, it is basically amyloid precursor protein. They are monoclonal antibodies. They have shown to reduce the MMSE scores in patients who have dementia less than those of control. So we have given these injections. So all patients of dementia, they decline. So the scores go down. But it is less so in those patients.
Not all patients, only mild patients.
So because it was done for a long period of time. So with time, yes, 18 months is a long time, sir, for patients with dementia. 18 months means 1.5 years, sir. And in fact, it was declined, but it was less so when lecanemab was given. Whereas with other drugs, it was well more. The placebo group was more. So that's the reason it was approved. So it is definitely on a better stage as compared to lecanemab. But still, I would not like to use it in my patients because it is very costly and it is still not available for commercial use. It is only available in select centers for trial purposes.
Very true, sir.
And secondly, for the biomarkers, area is basically whenever these such drugs are given, basically there is an increased permeability across the blood-brain barrier. So
amyloid imaging related, there are changes, especially the edema around it, and there are increased chances of brain hemorrhage surrounding those plaques. So there has been bleeding and some deaths have been reported. So that's why we are very apprehensive. We would like to give such drug which may help the patient. If even one patient dies, our hospital will be shut down. So we don't want to engage in such activities which we are not very sure of. So maybe not now, maybe in future, when we have more evidence, then we will think of it.
So Dr. Chaudhary, those were micro bleeds which could occur as it is. So this is basically an antibody binding to the beta amyloid, the alpha beta amyloid. So these changes are seen probably in all patients.
No. It's only in those patients in whom
cerebral
blood-brain barrier
swelling was seen in about 30% of the patients.
Like blood-brain barrier was breached.
Of course.
Antiplatelets, most of those patients are under them. So they are likely to bleed. Because only in those patients, they are likely to have this complication.
Talk us through the recent biomarkers.
Yes, so biomarkers, as I told you, it is CSF based.
SOBA and the urinary biomarker, the latest formic acid.
Those are not approved. Not approved.
In the pipeline.
So what we are approved, I will tell you, what we are using it for trials are mainly CSF, beta 42, their level go down, and phosphorylated tau and total tau, their level go up.
Just one more minute, please.
Then we go for PET scan. PET scan, FDG PET will show some changes, functional MRI will show some changes, but main is the PET MRI and the tau MRI. So those are the important things.
Great, sir. So my last question will be to my friend, Dr. Arnab. So let's discuss a real world scenario patient, Dr. Arnab. A 70-year-old lady, friends, this is a very interesting case. A 70-year-old lady, hypertensive, smoker, heavy smoker, and had a previous TIA, right-sided hemiparesis, stenosis, the LICA. LICA is the left internal carotid artery. After an uncomplicated left CEA. What is CEA, friends? Carotid and artery. So which is the modality of choice? If you have a high stenotic lesions of say about 99%, she had that. This was done. She was extubated, transferred to the NICU. NIC is critical care unit in stable condition. Except that the patient's blood pressure was high. It was 220 by 120, friends, for which she received IV levetolol and hyperglycemia as well. Over 4 hours to control her blood pressure. Suddenly thereafter she becomes increasingly somnolent and unresponsive after 4 hours. After 4 hours of the endectomy, CEA. Also, anasorkia. What is anasorkia? Where is Dr. Tulsi? What is anasorkia? Anybody, friend? Yeah, anasorkia. Absolutely. So, friends, different sides of the pupils, unequal pupils. She developed that. And she also, after some time, she was intubated for airway maintenance. And she developed dilated pupils, not reacting to light. Hold on, let me complete. Very interesting. CT reveals a large temporoparietal ICH with a 2 millimeter midline shift. Everybody is nodding, everybody knows the answer. She was given IV mannitol. the chances of meaningful recovery was very little. So it was explained to the patient's relative, and they said, okay, we don't want to intervene further. She died post-operative day 1. So friends, what was wrong here? Have you heard about the hyperperfusion syndrome? Dr. Kalra, have you heard about that?
Yes, no. Just now.
He heard just now. Okay, go ahead. Okay, what could have been done here? Right, very interesting question. What could have been done here? What went wrong?
BP was so high.
Yes, no, hold on. So there are two things. So carotid endarterectomy is still a risky surgery, let me tell you. So when you ligate by putting a clamp or a clamp, which artery to open first, that is important. So it should be opened the distal one first to get all the plaques out, rather than opening the proximal one. Number one. Number two, when there is a BP change, so Dr. Arnab will answer that. The basic line is
So when we were in Max Saket, we did not extubate these patients. For 24 hours, fear of NTPD was there, normal pressure breakthrough bleed. So we would not extubate, we would keep the patient ventilated. No, here it is. That's how we practiced it. We would not extubate at all. We would keep the patient.
He would not extubate for 24 hours.
For 24 hours. That was the practice there. I mean, I was a junior 10 years back, so I followed the protocol. CP situation should not be. But then I have also met a neurologist who said it does not exist. This diagnosis itself is normal pressure breakthrough bleed is a debatable thing. I have met a neurologist who said that this condition does not exist.
What went wrong and what should you have done?
Sir, that's what we would not have extubated. If I was still there, we would not have extubated.
How do you control the blood pressure?
Yes, blood pressure, the first thing is...
Let me add here, patient received IV labetalol and hydrogen. Instead of that, should we have given nicardipine?
Nicardipine. No. Labetalol is okay, but finally the BP should have been well controlled. Gradually, slowly. By reducing it will cause more harm than good. And emergency kinectomy would have helped the life.
How common is hypertension syndrome? With isolated hypertension. It's very common. Not very common. Thank you, sir.
No, please. The last question. Sorry to come in between your dinner. Sorry to come in between your dinner. And the question, I just want to put a comment there for Dr. Arnab. The question was posed as to what's the USP. Let me tell you that the trust. I brought